Hi, my name is Howard Goldman, and I'm a professor of urology at the Cleveland Clinic. I am also the director of the Urogynecology and Female Pelvic Floor Fellowship within the Lerner College of Medicine in the Goldman Urological Institute at the Cleveland Clinic. So when I diagnose a patient with overactive bladder, I go through the entire treatment algorithm, from most conservative therapy to advanced options. We start with behavioral treatments, so we ask perhaps about something like caffeine intake, because if someone's drinking a lot of coffee, just cutting back on that may do the job. We then also talk about non-invasive therapies like pelvic floor physiotherapy. We also will talk about pharmacotherapy, both anticholinergics and beta-3 adrenergic agonists. The guidelines recommend that we discuss the side effects, things like the impact of anticholinergics on cognition and the anticholinergics and dementia. If patients have had an incomplete response to behavioral therapy or pharmacotherapy, well then of course we discuss the advanced therapies at that point. So once we get to behavioral therapy and pharmacotherapy, I tell my patients it's sort of like running a marathon. You have to keep at it. If you stop doing the behavioral therapy, if you start drinking that coffee again, or you stop doing the pelvic floor exercises, the problem will come back. Same thing with medications. I tell the patients you're going to have to take the medication daily and probably for life. We also go through a complete risk-benefit profile discussion about whatever medication we are prescribing. Now, pharmacotherapy is clearly less invasive than some of the advanced therapies, but there are side effects even with pharmacotherapy. At this point, insurance coverage might be part of the discussion. Now, with removal of the tiered approach based on the SUFU AUA guidelines, you no longer have to go through behavioral therapy and pharmacotherapy to get to the most advanced options. However, in my experience, I found that most insurance companies will not cover the more advanced options without having at least tried behavioral therapy and pharmacotherapy. So I often ask patients, what is the number one thing you're trying to improve? Of the list of complaints, of symptoms, what really bothers you the most and what do you want to really work on? So we want to ascertain what's a win for that patient. And if the patient is willing to try conservative management, like pelvic floor physiotherapy or behavioral therapies, that's great, and we'll often work on that. However, if that's not working, then we will almost always move on to pharmacotherapy. If pharmacotherapy does not meet the patient's goals, if the results are not there, then we'll go on to more invasive options. At the end of the day, we want to see how much improvement does the patient expect and what are the different things they're willing to try. I usually try to have a patient report what their subjective experience as far as improvement is. But I often find that if you just ask someone how they're doing, they're often going to say, well, I'm better. But there's a big difference between being 20% better and 90% better. So I will often ask them for a percentage. What percent better are you? And if they say they're only doing 30% better, then I'm probably going to need to consider alternative treatments. And that's why it's so essential to follow up with patients after treatment decisions are made. And you don't want to wait 6 months to follow up. They're not going to come back at that time. You want to follow up once they've had a reasonable trial of whatever the initial or second treatments you've given them are. Now, the follow-up can be done by anyone in the office, by yourself, by a physician assistant, by a nurse practitioner. But again, you always want to ask them, at least I do, what a percent is. And if they say just 30%, then I'm going to ask them, well, is that satisfactory or do you want more than that? And if they say more than that, which most who are just getting 30% will say, then we're obviously going to have to try alternative, more advanced treatments. I think it's critical to ask the right questions. Find out what bothers them the most, and then ask the right questions so you can see how they're doing in response to treatment. I do like to hand out a questionnaire at the end of the visit, especially if time is short. That way we can compare how they're doing from visit to visit. We also do a lot of virtual visits and a lot of virtual follow-up via telemedicine, and I think it's wonderful if physicians have someone else trained, like a physician assistant or nurse practitioner, who can do those televisits, as it takes a lot of the pressure off of the physician.